Hello, everyone, and welcome to another episode of the Low Carb Lifestyle Podcast. I am very excited to bring you Dr. Rowena Field today. Thank you so much for joining me on the podcast.
Thanks for having me. I'm really looking forward to having a chat.
I'm really looking forward to chatting with you too. You have done some incredible work in the pain management space, which I'm really, really interested in learning all about and sharing with my listeners. But first of all, maybe would you mind introducing yourself? Tell us a little bit about you, what you do, and I guess what brought you into the low carb space.
Yeah, sure. So I'm a physio, and I've been a physio for 30 years now, so that makes me sound really old.
You don't look old.
Oh, thank you. I work in private practice. So I run a private pain management program with a psychologist, and we've been doing that for probably nearly 10 years now. And I guess that's an area that I've sort of ended up in. Like most of us, we have personal experiences that shape where our careers go. So I had chronic pain and didn't find really great answers in my own sphere of, understanding and education, and had to go looking for other answers. And that's why I ended up specialising in the area that I do. And I guess in terms of nutrition and how I came into low carb, that was just sort of like a separate parallel story that was going on at the same time. I was, the typical chubby teenager that always struggled with weight, living through the 80s and the low fat and aerobics era, and always trying to fix, my weight issues with that, and having to work pretty hard to keep it under control, doing it that way. And then probably, I don't know, it's probably 10 years or now, I guess I stumbled across low carb diets and was intrigued, because it obviously was sort of the opposite to what we'd learned back in the 80s, and tried it, and it worked for me. And then I as a clinician and a scientist, I guess, got interested in the nuts and bolts of how it works and how it affects our physiology. And then my two worlds collided. So there was lots of stuff about low carb diets and ketogenic diets that affect our physiology, but also affect our nervous system in a way that we're trying to affect our nervous system from pain management angle. So I was that person sitting in the pain conferences, listening to them talk about what the new fabulous drug was that was going to try and reduce a particularly inflammatory pathway, and my ears would prick up because I'd heard that back in some podcast about the keto diet and what that was doing in the nervous system. And it was sort of like I had two separate silos, and I was standing in the middle saying, like, you guys should really talk to each other, because you could learn a lot from each other. And that's how I guess fell into a PhD, as well as I went back then to have a look at the research, and so there must be lots out there. Other people must have looked at this stuff. And when I actually went and looked, nobody had actually done it at all. So I thought, I could, and I guess at the time in my life, my kids were growing up and they were sort of finishing high school, and I thought I can be a little bit self-indulgent here now and go back and do this PhD. I'd actually started a PhD when I was much younger, in my 20s, when I had toddlers, and that ended very poorly, and I promised myself at the time I would never go back and do that again. However, I found myself just intrigued by this whole question of low carb diets and pain management. So I signed up again, and I've just finished last year doing that PhD. So it was a hard slog, I must say, but it was enjoyable because it was something that I was really interested in and wanted to do as well. So that's how I've ended up where I am now.
Yeah. Oh, fantastic. So what was the actual title of your PhD? Was it low carb and pain management?
So it's using a low carb ketogenic diet for chronic pain, was my thesis. Yeah. So it was looking at ketogenic diet. So it was a bit, I had to find a supervisor that was a bit game when it came to doing that. But I had a bit of a false start with my PhD through another university that we won't name. It turned out that the head of the research was also in the Dietitians Association, and decided that wasn't a PhD that I was going to do. And so I pulled out of there and ended up at Sydney Uni with Kieran Rooney as my PhD supervisor. So I'm not sure whether you know Kieran or not, but
definitely
you might be
know.
aware.
Yeah, off him.
Yeah, so he was he's a little bit of a cowboy. He was one of the guys that, I don't know, you probably heard Gary Fecky talk about the cereal industry memo things that went out that named a lot of the Australian people that they were going to target. Well, Kieran was the only academic in that list of people that were to be targeted as well. So I
Wow.
picked him as my PhD supervisor.
Yes. He's yours.
Yeah, and he's been really good. And I must say, he's very balanced, and he's always, you know, made me work hard to prove the things that I was saying. So he's been really good as a supervisor. And yeah, so he's actually got quite a few talks on low carb down under on YouTube and things too, because he did a lot of research around sugar. He does a lot of animal model or mouse model research and things. So yeah, he's a good person to have a look at too.
Yeah, definitely. He must come across, you know, in his position. Oh, I mean, he must just have thick skin now. You know, he's probably just so used
Yeah, he
to
does.
what he cops, you know. The cognitive dissonance that comes out of that place sometimes just astounds me. But anyway, it's fantastic that there are people like him.
He's also the
Uh,
supervisor for Jess Turton, who you know well as well.
yes.
So
Yeah.
he's got a few radicals in his group. We're a bit of a
Good on
bunch.
him. Yeah. Oh, no, that's awesome. So did you find, you know, did you find what you set out to find with your research?
Yeah, well, yes and no, in that there were some surprising outcomes, I guess, and things that we weren't necessarily expecting to find. And I guess if we sort of, do you want to talk about the clinical trial that I ran? We can sort
Yeah.
of just run through that quickly. So what
Yeah.
we ended up doing as sort of like the final project in my PhD was a randomized clinical trial looking at whether a ketogenic diet was going to influence pain outcomes. And so to do that, we approached it a little bit differently to a lot of other research where they will randomize two groups and one group still just keeps doing the, you know, standard, you know, Western diet, and then we put them on another diet, and whatever the diet of interest is. And the problem that we saw with that is that there's a lot of arguments about, well, all you did was clean up the diet. And we could see that in some of the systematic reviews that we did as part of the research, was that, you know, you can put anybody on any sort of diet for pain management, and it doesn't really matter what that diet is. It could be vegan, vegetarian, Mediterranean, anywhere along that spectrum, and they will get some sort of benefit. And we think that's because you're cleaning up their diet a little bit when you put them on a
Mm.
diet. So that was the thing that we wanted to really make sure we addressed when we did our trial. And so what we did instead was we put everybody on a 3-week run-in diet to begin with, where what we did was we pulled out all of the ultra-processed food. So we used a thing called the NOVA classification. I'm not sure if you've seen that or not, but it's sort of basically a four category classification with, you know, green and red. And so your red items are all of your ultra-processed food. So, you know, your chips and lollies and the usual
Mhm.
culprits that you would expect. So everybody had to pull all of those foods out to begin with. So for 3 weeks they did that. And then at the 3-week mark, then we randomized them either to keep doing that clean diet or to instead do or continue that diet, but then pull the carbohydrate down to ketogenic levels as well, so that we could actually compare the two and make a better comment about what was going on. And I guess in the end,
Fascinating.
you know, the real world, I would have loved it to have been that, you know, the keto diet was fabulous and the other one didn't make that much of a difference, but the other diet did make a difference. So the people that just pulled out the ultra processed foods, even though they weren't aware of, we didn't talk about carbohydrates or anything like that, all they did was pull out the processed junk, they
Mm.
got a significant improvement in their pain outcomes as
Mm.
well. So when you look at the numbers, just in terms of whole numbers, the keto diet, their pain reduced a bit more, but it wasn't significant between the two groups.
Oh,
So
that's
I
interesting.
guess from a clinical perspective, then when we're talking to patients that have got chronic pain, you know, we don't just say, okay, well, if you can't do a ketogenic diet, don't bother, sort of thing. Like that,
Yeah.
I'd say if you can just pull the processed food out of your diet, there's a good chance that you're going to get a pain improvement just by doing that. And if you cope okay with that, then we might come and talk about carbs further down the track, because we can probably fine tune that and make it a little bit better. Because when we looked at the
Mm.
group that did the ketogenic diet, both groups got a pain improvement, but the keto group also significantly lost weight, improved their depression and anxiety scores, and also reduced their inflammatory markers on blood testing. So they got extra benefits out of doing that. So there's definitely reason why you would try and encourage somebody to reduce their carbohydrate as a pain management strategy. But if that's all too hard for somebody, just trying to help them to clean up their diet a little bit is also going to help. So I think as clinicians, we really need to realize, our target audience and not expect them to do something that's just, a bit overwhelming to begin with. And then let's ease them into that.
Into it. Yeah. And that makes a lot of sense. So with your keto group, were you testing for ketones? So you knew they were making ketones and things like that? Because the reason I ask is it is interesting, because I've done work with Georgia Eid. I did her clinician's course, and she was very clear to say that, for mental health, which is why it's not surprising the findings that you got with people that did actually go keto, because the ketones are, really where we get the benefits in improving mental health. So that's so fascinating to me, because I think there is degrees, but then we need to look, well, what are the issues that, the person in front of you is experiencing? And easing them into that is a great way to do it.
Well, I think the ketones are an interesting part of the story, and something, again, that was an outcome different to what I was anticipating, because I was going in very clearly. I had built this PhD around the idea of, ketones being present and what those ketones do to the nervous system. And we can talk about all that sort of stuff later. But I was expecting that we needed to get really good ketone levels in there to do all these magical things that ketones were going to do. And so we gave everybody, one of those Libra, ketone and like glucose finger prick monitors. And so they had to monitor their ketone levels throughout the study. And they were supposed to be using that, I guess, as an objective way of measuring how they were going. So we didn't sort of go in and say, okay, these are the exact foods you have to have. I'm going to count how many carbohydrates. We sort of went in and said, okay, let's start your diet here, and you're going to measure and see whether you've got ketones. And if you haven't, then you haven't pulled your carbohydrate down enough. So you're going to have to do it a little bit more. So it's a very objective way of knowing whether, for that individual, whether they've pulled their carbohydrate levels down enough. And even though we did that, we struggled. So part of the protocol for the trial was that we decided that they were going to measure their ketones first thing in the morning, because, you'd have to try and standardize everything when you're doing a trial. Yes. And that turned out to be a bad idea, because ketones are actually quite low in the morning. If we actually decided to measure them in the afternoon, that probably would have been significantly higher. Yeah. But when we looked at the average ketone level for the ketogenic group, it was still only like 0.4 or something like that. It wasn't, I was expecting it was going to be 1.5 or something. And we certainly did have some people that got up to those sort of levels. But it wasn't as high as what I thought it was going to be. And yet they still got good outcomes from that. And I guess you sort of have to then think about what that group looks like, because anybody doing that ketogenic intervention, we had some that they went into it and they were gung-ho and they did it, and they had higher ketone levels and they were really perfect with how they did their diet. And I certainly had people in that group who didn't do it very well at all. So
like normal life.
Exactly. That's real life. So that group, then when you average it, the average comes out looking like something, but there's going to be participants in that group that did really well and had high ketone levels, and participants that didn't do well and didn't have ketone levels. So perhaps, if we'd had enough numbers to be able to sort of separate that out and untangle that a little bit, we might have found that, the people that had higher ketone levels did better on some of those scores. But because it was only a pilot trial and we didn't have that many people in it, we really couldn't do that sort of level of analysis either. But I suspect still that we need to have some sort of, reasonable level of ketones in there to get the results that we want. But also, that being said, we know that our bodies adapt too. So, the higher ketone levels that you see at the start of somebody commencing a diet like that, they tend to settle back down to reasonable sort of levels. And I see that even myself when I measure my own ketones. They're often only sitting at lower levels, like, 0.4 or maybe 0.5 or something like that on a good day, even though I've been very strict with, what I'm eating. So my body adapts. Puts the amount of energy in the system that's really required. Our bodies are very...
clever.
They're clever, and they don't overcompensate for, like, you know, why waste stuff? Like, it's going to modify and modulate to keep things at that homeostatic level where everything runs nicely. So we would expect over time, of somebody doing a diet over a long period of time, that those ketone levels would settle back down. But still, they're getting the benefits in the nervous system and stuff that we were looking for in the first place. So that, I guess, was one of the findings then from my PhD, that I came back and said, okay, well, it's got something to do with ketones, but it's got stuff to do with other things as well, because we're doing more than one thing. Yes, we're getting some ketones in the system, but we're also reducing glucose. So, and that in and of itself has its own effects of things that it does. So we know that, you know, glucose is a bit of a naughty molecule, and it sticks itself to proteins and stops those proteins working correctly, which is what happens with a diabetic. So the glucose is sticking to the hemoglobin, and that's what you get when you measure, you know, your HbA1c and those sorts of things. But it also sticks itself to the proteins in your tendons and your ligaments and the cartilage in your joints and your nerves, and it impacts how those things function as well. So if all you're doing is helping to, you know, stop those peaks and wild sugar excursions that you're getting, and keep your sugar levels a little bit more stable, then that's having really good flow-on effects to your physiology as well, without necessarily having produced ketones. And I suspect that's probably what was also happening in our whole foods group, because even though they didn't radically reduce their carbohydrate, they did actually reduce their sugar level. So they might have been at, like, you know, 350 grams to begin with, and just by pulling out the junk food, it came back down to like 150 or 180 or something. So it still was higher than what we would class as a low carb diet. But for them, they reduced the carbohydrate they were taking, and they probably flattened out their glucose spiking as well. And so that's going to have an impact on pain.
Yeah. Oh, it's so interesting. You know, but back to when you were measuring the ketones. So was it as soon as they got up in the morning, or did you say, like, wait half an hour, or was it just as soon as you got up?
We just told them to measure it before they had breakfast,
Oh,
essentially.
before they had breakfast. Yeah, no, it's interesting because, again, like, it was brought up in someone asked the question because about the dawn effect, because we know, obviously, you know, cortisol getting us up and all that, and
Yeah,
that can affect ketone levels. But it was asked by, you know, the question to Dr. Georgia Eid about that, because she says to her patients, check about half an hour after you've gotten out of bed. And, you know, I said, but, you know, would it be better to maybe check a bit later in the day? And, you know, her point was that actually, you know, if they're eating, you know, a proper diet, if they're eating it properly, the dawn effect should only be just so little that, you know, by the time, you know, they actually get up and get walking around, it should normalize. But it's just really interesting because I think, you know, obviously she's, you know, looking mental health. That's her focus. But I just think there's so much we don't know about all the
and that was something I hadn't even thought about before.
Mm.
Obviously, we were going, and that's why you do pilot trials, to, you know, iron out all those wrinkles. And if we were going to do it again, I'd probably get them measuring morning and afternoon or something like that. But even just when I was testing myself, I would find that my ketone levels were much higher mid-afternoon than they were in the morning. And obviously, there's reasons for it that you'd have to dig around and try and figure out. But it's going to impact, you know, what your results are in a trial if you haven't thought those things through.
Yeah, absolutely. So are you going to do it again? Not yet.
It's one of those things when you're doing it at the time, you're thinking, you know, I'm never
Never.
do this again. It's like herding cats. There's people going everywhere, and you're trying to keep them all on track and keep people away from the edge. No, you can't drop out. You can't drop out. It is really hard work.
Yeah. Oh gosh, I can only imagine. Well, I'd love to chat to you then. I've got a few questions just to help people understand, you know, what really is chronic pain. So can you explain what the difference between chronic and acute pain? What's that difference?
And it's a really important distinction to understand. And I think even health professionals don't understand this concept very well. And what we tend to do is look at everything as if it's an acute pain problem. And the big difference, so chronic pain gets defined by, like, how long since the injury and all those sorts of things. So it's usually, you know, 3 months at least after normal healing time should have occurred, is one of the definitions. But the big distinction, I think, between acute and chronic pain is that with acute pain, there's some sort of new tissue damage. And with chronic pain, you no longer have new tissue damage. There's other things that are now starting to drive that pain outcome. And so the analogy that I usually use to my clients when I'm trying to help them understand it is that of a car alarm. So if you think about what a car alarm does and what pain does, pain is a protector. It's the thing that your brain does to smack you up the side of the head and make you take notice when something's going wrong and you need to fix a potential problem. And so a car alarm does sort of the same job. So it's designed to go off and tell you when somebody's actually in real time breaking in and stealing your car. So that's how acute pain works. So, you sprain your ankle or something like that, then you're likely to have a pain experience to make you take notice, put some ice on it, stop walking on it, allow it to heal, that sort of thing. So that's great. Works great in an acute scenario. But what chronic pain is, it's a little bit more like our car alarm. Somebody's got it and they've now turned it up so it's super, super sensitive. And now everything sets the car alarm off. It doesn't matter, bus rumbles past, car alarm goes off. Bird flies overhead, car alarm goes off. So it's not that the car alarm is not real. The pain that person is experiencing is very, very real. And the car alarm is still doing the job that it was designed to do, but it's no longer now giving you good information about what's actually happening to the car, because nobody's breaking in and stealing the car anymore. The robber's long gone at this point. And so we've now got a different problem happening. We've now got a problem that it includes a little bit of the structures that were heard in the first place. Like they've still got something to do with the story, but now we've got this other secondary problem going on as well. And that's a problem within the nervous system that looks after that body part. So we've now got a nervous system that's super, super sensitive and sending back danger information to the brain all the time for the brain to go, oh, hang on a minute, things still aren't great. I need to protect. Pain is the appropriate response for that. And so we're really trying to, we need to treat chronic pain very differently to the way we treat acute pain, because they're two different things, two different beasts. And if you treat chronic pain like it's an acute pain problem, you invariably make chronic pain worse. Because if you're doing something that you're continuing to push that experience, and they're having chronic pain and flaring it up all the time, all you're doing is making a bigger and better car alarm. You're just building the problem. And so we really have to take a step back from this problem and say, okay, well, let's look for this person, what's actually gone into their story that's now wound up this car alarm, wound up the sensitivity in the nervous system. And how do we now change that so that it's coming up with a different answer? Because our ultimate problem with chronic pain is that the brain is subconsciously coming up with the answer, things aren't great, I need to protect, let's turn the pain on. The answer that we need the brain to come up with is, oh, hang on, it's not quite as bad as what I thought it was going to be. We can start to wind that protection down a little bit. And so the way that we treat chronic pain needs to be very different to the way that we treat acute pain. And that's why we don't do it very well either. Because if you think about, we're really great at acute pain. Like if I go out the front here and get hit by a bus, I want you to take me to A&E because they're going to know what to do. They're very good. They'll, give me an MRI scan and hopefully they'll give me some drugs and, they'll put my arm in a cast that I've broken, whatever it is. That's great. We do acute pain really well. But if I've still got chronic pain in my arm that I broke a year down the track, rocking up to A&E is a total waste of time because they're still going to try and do the same sort of thing. They'll probably give me a scan and they'll probably give me some drugs and they'll probably put it in a sling and tell me to rest it. And they're all great if it was an acute pain problem. But now I've got a chronic pain problem and that's no longer really the things that are driving this. So we have to manage it differently. And that's where things like diet and stuff come into the story, because we have to stand back and look at the 1,000-foot view for this person. We need to sort of not really look myopically at the structure or the thing that was hurt in the first place and start to look at the person as a whole and say, okay, why is their brain coming up with the answer that protection is still required, and what can I do to change that? Because when the brain's coming up with that answer, it's not just the thing that was hurt. It's like, well, is my blood pressure out of control? Is my blood sugar out of control? There's all these other metabolic things and stuff that goes into that little equation that the brain is coming up with. So we've got an opportunity to change those things through diet, through other lifestyle interventions, and they tend to get the they get poo-pooed a little bit in management. It's like, let's do everything else. We'll do all the surgery and do all the drugs. And if everything else fails, well, let's do some lifestyle management. Let's get them to, work on their sleep and their diet. And what does that even mean?
Yeah, exactly.
Nobody really knows. Whereas it's the lifestyle stuff should really be coming back at the front of all of this and saying, okay, well, actually, if you're not sleeping well, that's driving this nervous system problem. And if your blood glucose is crazy, then that's also, because we've talked now about how glucose can affect the nervous system, that's impacting the problem as well. And what about if, you're anxious and you're worried about you're going to lose your job and all of that? So the psych stuff becomes important in all that too. So it really does take a bigger picture look at what's going on to help somebody with chronic pain.
I think that is fantastic. I love the way you've described it. I've never heard it described like that. And I think that makes it so clear for people to understand the difference. And I find it interesting that you said at the start too, you have a psychologist working with you. Well, that kind of makes sense now, doesn't it? If you look at all this brain stuff going on. So can we maybe talk a little bit about that now? So in a real world example, say, a lot of my clients, a lot of people out there have chronic back pain, lower back pain, for example. So if someone like that was to come to you, so what would be this bigger picture view, these puzzle pieces that, obviously this is just a made up example, but what would you look at as important factors within, in looking at that big picture view?
So when we take people into our practice, the psychologist and myself, we sit down with the person together and we run through their pain story, because the context of what's gone on for that person and all the things that they've experienced up until that point have shaped the experience that they're now having. And so we need to look at all the physical factors and all the psychological factors that go into that to see, well, why is their brain coming up with the answer that it is coming up with? And, a story I often tell my clients to try and help them understand this is to say, okay, well, let's just imagine that we've got a busy stay-at-home mum and she's raced through the dining room and she's cracked a toe on the corner of the dining room table. So she's now said a few choice swear words and she's looking down at this toe that's starting to, swell up a little bit and go a little bit bruised. Now, if we think about what's going on for her, so we know she's got an acute pain problem at the moment. She's probably got some new tissue damage in that toe. And if we think about this from that threat and safety perspective that we were talking about, how likely is that to become a chronic pain problem for her? Well, probably not that likely. She's probably going to have a little bit of stuff going into both of the sides of that equation. So there'll be some things in the danger side, like, I don't know, this is so inconvenient. I had all this stuff that I had to get done this afternoon, and who's going to pick the kids up from school, and I can't get my shoe on. So there's some stuff in there that's probably a little bit on the worrying side. But there's also going to be stuff on the other side, and that includes things like, well, it doesn't matter, it's the weekend. I'm going to just wear my thongs and binge watch that thing that I haven't got around to watching on Netflix, and my husband can do all the housework this weekend. So all things being equal, and I guess the other thing that goes in there is knowledge as well. So there'll be knowledge like, well, even if I've broken my toe, if I go and see the doctor, he's just going to look at me and go, yeah, you've broken your toe. We don't do anything for broken toes. See you later. So as this rolls out, she's going to have a sore toe for, maybe a couple of weeks. It'll go through the normal healing process, hopefully. And we get 3 or 4 months down the track, she's probably going to forget which toe it was she actually kicked on the dining room table. So that's our standard sort of story. But now let's change the context and say, instead, she is now the lead ballerina for the Australian Ballet Company, and she does the exact same thing. So already you should be sort of saying, okay, this is going to be a little bit different for her, because the way her brain is going to calculate the probabilities and the impact of this is going to be a little bit different. So already through her head is running, oh my goodness, I'm going to have to ring the director and explain to him that I don't think I can dance tonight. This is going to be so inconvenient. It's going to cause such a hullabaloo. What am I going to do? Maybe I can dance. If I can get my foot in that shoe, that ballet shoe, maybe I can still do it. So she goes off to get a ballet shoe, can't get her foot into the shoe now because the toe is so swollen. So you can imagine now she's already, starting to get that, anxious feeling in her chest and thinking about all the things she's going to have to do to solve this problem, and a little bit worried about the chick who's the understudy, because, if she's going to get to dance her role now, and what if she's better and they keep her and they don't take me back in again? So there's all these cognition things starting to run in here. So already the way that her brain is assessing this situation and anticipating what needs to happen is very different to what happened with the other lady. And so she thinks, right, I'm going to go to the doctor, and maybe he's got a magic wand or something that he can put over my toe and make it get better quicker. So off she goes to see the GP, who takes one look at her toe and says, it's not going to be my fault if there's anything wrong with your famous ballerina toe. I'm going to send you to my mate, the orthopedic surgeon, and let him check it out and make sure it's okay. So he offloads her off to the orthopod, who does an MRI and then sits down with her and says, oh, this is not good. Have you seen the MRI scan result? You've got bone on bone in that big toe joint. So can you now imagine what's running through her head and what she's feeling in her chest as all this? So she's got all these, thoughts about, well, I've got dancing friends that had arthritis in their toe and they had stopped their career, and she's now got this mental picture of these bone on bone grinding on each other. So all the things that are now going on to the threat or the danger side of her equation are really quite significant. And so the way her brain is then going to respond to that is going to be to start to upregulate that nervous system that we were talking about before. And the problem is that, she's done nothing wrong in this story. Like she hasn't done anything incorrectly. It's just the circumstance and the context around her story has meant that her brain has evaluated that danger information differently to what it's done for the other lady. And I guess one of the problems is that the information that she's using is not necessarily good or correct information. And so what I mean by that is that the MRI scan results, she's now got this, terrible picture of the bony surfaces grinding on each other. But unless the orthopod sits down with her and says, look, this hasn't happened in the 2 days since you kicked your toe on the dining room table. This has been happening for the 15 years that you've been dancing at an elite level on the point of your toe. So if we look after this acute injury at the moment, maybe we'll get you practicing your dancing in the pool or something so there's no weight on your toe. There is no reason why this won't heal and you'll go back doing what you were doing before. So if he did that, it would change again how the brain is going to answer and understand that situation. But if all that happens is she walks out that door with the mental picture of the bone on bone grinding, then every time she goes to do something and it hurts a little bit, her brain will join those dots and go, well, of course it's going to hurt. You know what that MRI scan looks like. And so our brain does this thing of, just taking all these little bits of evidence that are parked on shelves in the back of our brain somewhere and pulls them forward and tries to juggle them into some sort of answer about, am I safe or am I not safe? And if I'm not safe, then what I need to do is protect. What is one of the protection mechanisms I've got? To turn up the sensitivity in the nervous system. And so this is very much, I guess, the new approach to pain management now, is saying, what we've been doing, what we've been throwing at the system up until now has built what you've got. If we don't change what you're doing and what we're throwing at it, it's going to keep doing what it's doing. So we really have to look at what's going on for that person and what can we juggle around and what can we change to get the brain to come up with that answer. Oh, wasn't quite as bad as what I thought it was going to be. And diet is a really great way to do that, because if we can make somebody think, oh, I've changed my diet, I'm eating well now, that's going to be good for me, I've lost a couple of kilos, going like that, all then starts to add into the safety side of it, apart from any of the physiological changes that are going to be beneficial as well from changing that diet. Sorry, I got on one rant there, didn't I?
No, I love it. I love it. I find it so fascinating, the power of the brain, and how, when we can understand this, what layers and what other opportunities and what other choices it gives people, rather than the standard, hey, take a pill and, rest. Yeah. Sorry, that is fascinating. And now it makes complete sense why you have a psychologist, working with you.
She's brilliant.
Oh, I can imagine. But, that to me, like most things, we want quick solutions. That's obviously a longer term, but highly worthwhile pathway to go down, but would require a lot of trial and error, I'm assuming, and trying different things. And, obviously, setting the patient up to say, look, we're not going to flick this switch overnight. How do we, that's a really interesting, thing with thoughts and how we get hooked by certain thoughts and hooked by certain stories. I mean, I bring that into my coaching because it's fascinating when you start to really look at that and understand it. But it's not easy to create a new story, I guess was what I'm saying. And
yeah, and that's
yeah.
why working with psychologists makes this really great, because that's part of the recovery process, is even just being aware that those thoughts are doing what they're doing in the first place, and
Yeah.
they become their learned behaviors. So you can't just flick a switch and turn those off, but just being aware that's what you're doing then starts to give you the opportunity to inspect that thought that you're having and maybe change the narrative around what you're saying in your head. Or that there's lots of unhelpful thoughts that we roll around in there and never necessarily tell anybody about or expose to the world. But our brains like to default to worst case scenarios. We always sort of, am I going to be okay? How's my back going to be? Am I getting out of the car the right way? What if I have to sit too long on a hard chair? All these sorts of things roll around in our head. But being aware that that's what we're doing and that it is winding into the problem gives us an opportunity to then start to do something about it. And obviously that's what she works a lot with people with. She's got lots of little tips and tricks to get people working on that sort of stuff. But our cognitions and what we think is happening is a really, really important part of this story. And a lot of people have some pretty solid beliefs, we find, when they come into the program about, okay, well, my injury still, it hasn't healed and I haven't seen the right doctor yet, we just haven't had the right surgery. So dealing with some of those concepts can be a little bit tricky with people, because they don't, you're challenging them on something that's a deep held belief. But we know from the new research that's coming out that if we can change what people are thinking and change their beliefs, you can absolutely change their pain outcomes.
Yeah. Oh, fascinating. So much hope. That's what I love about it. There is just like so much hope. I remember listening to a podcast a while ago, because I try and source this stuff because I find it really, really interesting. I mean, they know even with giving someone immunizations, for example, the way they think about that in immunization actually affects the outcome of it.
Absolutely.
Yeah, fascinating. And they've even done. I don't talk about this one a lot because I find it really interesting. But they've even done studies with telling people when with drinking glucose versus not, and they've told them the opposite to what that is the truth. This tastes sweet. It's not glucose. There's no glucose in it, but this one does, and it actually affects their blood sugar.
Yeah, and it'll change hormone levels. So our thought-based physiology is a huge area of research. Like, there's so much based on what we think that changes how our body responds, which I find is really fascinating, because we look in the textbook and we say, okay, here, this hormone acts on this cell in this way. I think, yeah, well, that's great, but you've disconnected the brain from that story. And if the person thinks something differently is going on, then that might not necessarily be the textbook response that person has. And so we see that all the time. And a lot of the new approaches, I guess, for pain management are very much about, it's almost like trickery, trying to trick the brain into coming up with a different answer. Because if we can trick it into changing that response, then we can change the outcome that's going to happen. And there's lots of, they're doing a lot with like virtual reality and things around those sorts of experiments. So you'll see stuff. One I love that so in Adelaide, they're big on pain research over there, and they do lots of these really cool trickery experiments. And they'll do things like get somebody with chronic neck pain and get them, they measure sort of like how far they can turn their neck, and then they'll put virtual reality goggles on them. And what they'll do is change the visual input so that as they're turning their neck, instead of the vision tracking with where the neck is going, they'll make it so that it actually goes further than the neck actually does. So you're essentially setting up a situation where the eyes are lying to the brain about how far the head is turned, and you can increase somebody's pain by doing that, even though physiologically, like nothing's changed with their neck joints or anything like that. They haven't moved any further than they were happy to do before. But because the eyes have said, oh my goodness, you've just turned your head way past where you should, that's then a danger signal that comes back to the brain that's going to be misinterpreted then by the brain as a problem. And so pain is going to be the appropriate response to protect. And then they'll do what all good researchers do and do the opposite to what they did. And this time they changed it so that instead of the eyes going too far, the eyes hardly moved at all. So they actually turned their neck further than the eyes said that they did. And what they found was that they actually turned their neck further without an increase in pain. So you think about
phenomenal.
Think about the implications of that. And you know, so a lot of what we do so me as a physio treatment wise with people with chronic pain, after we've done the education, we do a lot with graded motor imagery and things like that. So trying to get people visualizing you know, an activity that they can't do, because that's still then using the circuitry in the brain that's involved in physically doing it without them physically doing it and getting the danger cues that are coming up from the body. So there's all sorts of ways you can sort of manipulate and play around with the information that the brain's getting to try and trick it into that answer that we wanted to come up with, that things aren't as bad as what we thought they were going to be. So there's a lot of new research out there that's, I think it's got a lot of promise and a lot of hope for people with chronic pain.
Yeah, absolutely. Have you read Dr. Kelly McGonigal's work? Have you heard of her? Oh, you would love her. She has she's done a TED Talk, but she's got books, and one of the books I've read of her is it, I think is it The Upside? She's got The Upside of Stress and The Joy of Movement. And basically with movement, she goes into all of that. You know, how you see what you're doing, it actually changes the physiology of the body. I'll have to send it to you. It's fascinating stuff. Yeah, really, really. But all along those lines of how powerful the brain is to change the outcomes. You know, they did, she talks about a study where they had house cleaners, you know, cleaning, and they didn't think they were doing any exercise. But even though they're doing physical work, in their mind, they weren't actually doing any sort of exercise. So they always thought, oh, I wasn't, you know, I don't do any exercise in my day. So what they did was change the way they saw what they were doing and said, well, actually, you are doing very physical work. Like when you do this, you're working these muscles and, you know, you're working your heart doing all this. And over like 5 or 6 weeks, completely their fitness levels changed and they lost weight. Yeah, incredible.
By somebody, Crumb, C-R-U-M, there's I think she's a psychologist that's done a lot of that similar sort of work. And I think that was one of her studies that maybe this lady was quoting.
Maybe, yes. I think that's why it's familiar to me, that name. Yeah, fascinating. I think we can learn so much.
What your brain thinks is very, very important.
Yeah, it is. Well, I would love to talk for hours about this, but I will let you go. But I just have one final question for you. I guess with all the fantastic work that you've done, you know, how would you like to see the work you've done change the paradigm, you know, in the chronic pain space?
Yeah. I would just love to see it being adopted more back at like GP level. I'm not having to go at GPs because they've got such a hard job with the very small amount of time that they've got to try and manage somebody with chronic pain. It's really, really difficult. And I guess they always tend to, okay, well, let's try a new medication, or let's, you know, ship you off to another specialist. And the dietary change stuff really gets, you know, ignored right back at the start when it could really actually make a lot of difference. So I would really like to see that coming back, you know, earlier in the piece about trying to help people with their diet, and also I guess helping people to understand a little bit more about the, you know, the thinking and stuff that goes around chronic pain, so that they can maybe prevent getting into a chronic pain problem in the first place. So hopefully that starts to become a little bit more prevalent in, you know, in early management.
Yeah. It sounds fantastic. So where can people find you, Rowena? Do you only work face-to-face with people, or do you do online?
Yeah, we do telehealth as well. So I'm based in Nowra, so if people want to see us face-to-face, that's where we are. But yeah, as I said, we'll do telehealth anywhere in Australia as well. So we've got a website which is just STEP, so STEPP, so Solutions, Tools and Education for Persistent Pain is our website. So you can have a look at that and contact us through there if anybody wants to.
Brilliant. Well, I'll definitely have links to that below for people that are interested. It's been such a fascinating conversation. Thank you so much for sharing everything, and great to finally meet you and keep doing the amazing work that you're doing. Thank you so much.
Thank you.